So let's switch gears and talk about the endocrine pancreas briefly. So let's move on to the endocrine side, and that's where we have our islets that get secreted directly into the bloodstream. So here's a picture of an islet of Langerhans. And islets of Langerhans are simply collections of neuroendocrine cells that are scattered throughout your pancreas. We're going to go over each of the cell types. So alpha cells are the first type we'll talk about, and they're coded in red here, and they secrete glucagon. And so what I want you to know about glucagon is that glucagon increases your blood glucose levels, okay? And how I remember this is the mnemonic, you need glucagon when your gluc is gone. Because if you have low glucose, that's when you're going to see glucagon being released in order to increase our blood glucose levels. On the contrary, you can also have beta cells in these islets, and those are probably more famous, and you can see them highlighted in blue here. And beta cells secrete insulin, and insulin is responsible for decreasing your blood glucose levels. And I remember that as insulin brings glucose into cells. I always think of insulin as my storage hormone. It's going to try to package up everything into a bigger molecule. It doesn't like free glucose and anything like that. Okay, let's move on to delta cells. So delta cells secrete somatostatin, and somatostatin, as we've talked about before, it inhibits the secretion of many hormones. And I always remember somatostatin as somatostopin. And I don't have a cell type for it specifically, but I just want you to realize that these pancreatic islets also secrete other hormones on occasion, such as gastrin and VIP. And when we talk about the pancreatic islet cell tumors, we're going to find out that all of these hormones that we've discussed can be responsible for some sort of neuroendocrine tumor. But for now, what I want to just focus on from the physiology side of it is this mechanism by which beta cells are able to secrete insulin into our bloodstream. So here I've shown you a beta cell, and we're going to talk about how insulin gets produced and secreted into our bloodstream. So the first thing that's going to happen is that glucose that's in the bloodstream can enter the beta cell. Once in the beta cell, this glucose is converted into ATP, just like any other fuel or any other cell could. And this ATP is going to act on a potassium channel. So what I want to say before we move on is that these potassium channels, as you can see, they're pushing potassium outside, okay? And if you can imagine a bunch of positive ions leaving the cell, what's going to happen is that this space here will become more positive, whereas the inside will become more negative because you're losing a positive charge. And if you have a cell that becomes more and more negative, it's going to actually hyperpolarize the cell and make it less likely to perform an action potential. ATP, though, blocks this process. And so instead of all these potassium escaping out here, you're going to get potassium building up here. So you're going to get positive charge building up within your cell. So this increased positive charge inside the cell will ultimately depolarize your beta cell and cause an action potential. What's going to happen once your cell's depolarized, calcium is going to enter the cell, and then calcium can actually release insulin into the bloodstream and help with the vesicle release into the bloodstream. And this physiologically makes a lot of sense, because if you have a ton of sugar in your bloodstream, what's going to happen is this process will actually give you a lot of insulin, which can counteract that, and it'll force cells to take in glucose into their cells, and you'll be able to regulate your blood glucose levels that way. Some other things I want you to consider is that, and we'll talk about this later on as well, is that sulfonylureas inhibit potassium channels to facilitate this release. So they do the exact same thing that this whole ATP and natural glucose does, in that it'll inhibit this same channel. That'll also cause potassium release, and then calcium release, and then insulin release ultimately. Another thing I want you to realize is that C-peptide is released whenever beta cells actively secrete insulin. So as long as beta cells are doing the secretion of insulin, like packaging it into these vessels, you're going to get C-peptide released as well. So here's a vesicle here. If that's released, if it releases insulin, it's going to release C-peptide. This can happen in 3 different ways, okay? So we've talked about 2 of the ways already. The first way is that natural insulin production. So you have glucose coming in and going through this whole process that we've talked about first. In this process, you're going to get C-peptide released. Another thing that we briefly mentioned again is that if you have a sulfonylurea blocking this potassium channel, again, you're still going to get natural release of calcium and natural vesicular release of insulin. So you'll get C-peptide as well. The third thing, and I'll talk about this when I talk about pancreatic islet cell tumors, is that in insulinomas, your own beta cells are hypersecreting insulin. So because it comes from your own beta cells, you're going to see elevated C-peptide. I'm not going to do a full section on diabetes right now. If I ever do an endocrine section and this series is well received, then I would give a full diabetes talk, but I don't want to bog you down with all that. I just want you to know on tests, you should look for the classic polyuria, polydipsia, polyphagia, and weight loss for somebody with diabetes. Peeing a lot, drinking a lot, all that stuff. In type 1 diabetes, just know that it's from a lack of insulin production, so we don't even have our beta cells in the first place. Whereas type 2 is more about insulin resistance, where you have the beta cells producing a ton of insulin, but your other cells aren't reacting to it, and so sugar is just sitting in your bloodstream. Some nice pearls that you should realize: if you ever have somebody with diabetes and bronze skin, I want you to consider hemochromatosis. If you ever see somebody with late onset diabetes, I'd start thinking about a primary pancreatic disorder like pancreatic cancer or chronic pancreatitis. And it's really important to, if you have to review it, you can. The mechanism that we just discussed of how insulin gets produced and excreted. This is especially important, and I'll have a practice problem later when they test you about insulinomas versus normal insulin use versus exogenous insulin versus sulfonylurea use. I go over that later, but that's why this mechanism is so important to know. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.